Good morning, everyone, and I thank you all for being here as a last session. I am given this topic today morning, and I will share only the clinical pulse that will help us in preoperative evaluation. It's not going to be a book lecture, only the pulse, few of them, if we can follow, we will be successful in our outcome. We know that we have to reach the target intraocular pressure in all our patients so that we can achieve long-term success rate with good quality of life. And for achieving this target intraocular pressure, we have to either enhance the trabeculectomy, maybe by using some antimetabolites or antifibrotic agents, or you can use some implants or releasable suture, adjustable sutures, and you can modify your post-operative regime also. So pre-operatively, we have to evaluate our patient. This is to show you there are so many parameters that we are looking for. The first and foremost is do good clinical examination. Chamber depth is very, very important. When we are going to deal with the chronic angle closure glaucoma, the shallowing of the chamber is there from the very beginning. And when you operate, there is going to be a hypotony and the shallowing of the chamber further, and that makes our life very, very difficult. So we have to do the counseling to the patient on this aspect. It is essential to do good gonioscopic examination, disc examination. You can use the visual fields as well as the imaging technique as and when required. And this is essential as a medico-legal documentation. So, and I will emphasize more on a patient counseling. In our clinic, we do counseling at least 4 times before we take the patient for surgery. Particularly, these patients who are having advanced case of glaucoma, the chances of visual field wipeout is very high. Though, fortunately, we have not encountered any. But we have to tell to the patient that this is your visual field, there is a split, there is a tubular field, and you are at the risk of wipeout. The relative should also be informed. Otherwise, later on you may face some consequences. Always give guarded visual outcome. See, unlike cataract surgery, they cannot have a good vision on day 1, all of them. And you must be aware of this. After finishing this, after you remove the patch on day 1, they will start like seeing with one eye whether they can see it properly or not. So ask them or tell them that the visual outcome will be stabilized by the end of 1 month. Give a long time. So they should not complain to the surgeon. Then secondary intervention, always mention that we are going to do, how I do counseling, that is what I am going to tell you. I always tell to my patient that when you operate an abdomen for appendicectomy, you are not given any oral fluid for some days. So it is because all organs in the abdomen, they are going into the shock, and we are giving you IV fluids. Similarly, eye is also one organ, and after surgery it is possible that it might go into the shock and aqueous production may not be the same as it should have been. So in that case, you might have a shallow chamber in post-operative period. So I may take you into the OT and inject some air. And this is not a complication, but this can be needed in some of the patient, not in all. But this is how you should do the counseling. Second surgery in form of like you have an encysted bleb, then you may have to revise the bleb. Needling, you may have to do when there is a flat bleb with the rising titer. So these are the things which complications has to be narrated to the patient and has to tell that we might need any secondary intervention later on. Always mention if there is a lens in the eye, always mention it might be possible that cataract, which is supposed to be mature by 6 months, may be mature after 2 months. It is a rough, but patient has to listen to this because hypotony induces early cataract formation. This is nothing new. It is all science. And then he might need some post-operative glaucoma medication if required. We are doing this surgery to achieve the target pressure which you are not able to achieve with the drugs that you are using at present. So post-operative glaucoma medication may be required, and then mention the long-term failure rate. You might need second surgery later on. At the end of 5 years, you may not have a good success, and we might have to do second surgery, we may have to add. Then how you evaluate the proposed site? Always find out an area which is untouched, unscarred. It should be ideally done on superior side, preferably slightly on nasal side, so that you can keep the area for the phaco in future. Avoid extremes of nasals and temporal, because this blab will give a Dellen effect if it is an elevated blab. And I always prefer to avoid the inferior part because of the more risk of developing blabitis if the blab is in the inferior area. Now, in the subsequent lecture, we will show you how to evaluate the conjunctiva, how to pick up. But even on the slit lamp, like here, you just put your thumb on the outside part of the, at the margin of the limb, press it little bit and try to see the movement of the conjunctiva. Conjunctiva should be freely mobile. It should move from side to side or from up and down. That will ensure that this is an unscarred area and a good area there you can do the surgery. So with this this is the last slide for the preoperative preparation. How we do? Stopping the PG analog or blood thinner is surgeon's choice. It is not compulsory. There is a controversy or debate on this, but I do stop day before. And always maintain the low IOP before you open up the eye, and that's why in an advanced case of glaucoma, even though the pressure on table is going to be 20 or 24, I prefer to give intravenous mannitol at least 1 hour before the surgery. We put 1 drop of pilocarpine before we start the surgery. That will constrict the pupil, so later on there won't be any iris prolapse in the internal opening, and you can have a small buttonhole iridectomy. Preoperative antibiotic, nowadays we all are switching to the topical, but if your patient is not coming from a very higher class or exposed to the dirt, it is better to start the oral systemic antibiotic on the day of surgery for 3-4 days. We use the topical antibiotic moxifloxacin, and before 1.5 hours 5 times, and then 1 hour is observed for the MIC level to come up in the anterior chamber. Anesthesia can be anything, peribulbar or the topical. I lately use topical anesthesia when the good exposure is there. And avoid vigorous massage after the peribulbar in the advanced cases of glaucoma, or avoid applying super pinky because it will raise the intraocular pressure and there may be a compromised blood level in the optic nerve. So with this I will end this presentation.